Thanks, Somabhata, for your kind words. Thanks, Lectum Synergy, and for inviting me in this Indo-Diabetes Summit 2021. The topic is new next generation or second generation basal insulin, a new benchmark for redefining glycemic control. In fact, basal insulin is a breakthrough in the management of diabetes, in controlling fasting blood glucose, achieving better hemoglobin A1C, and in preventing nocturnal hypo attacks. But with the knowledge of glycemic variability, a better basal insulin is to be considered in the management of diabetes with lesser glycemic variability and less incidence of hypoattacks. And for this, we have a very good speaker, Professor Nilanjan Sen Gupta, at present Professor and Head, Nilratan Sarkar Medical College, Endocrine Department. Dr. Nilanjan Sen Gupta, please.
Thank you. Thanks, Lectum Synergy. Thanks, Somabhata Chaudhary, for calling me once again in your excellent annual scientific program. I'm following this over the last 2 days. So let me share my slides before I start my talk. So I think the sharing option has been given. Share screen, yeah. Is the screen visible in totality?
Yes, you need to make it full screen.
Yeah. So, thank you. So as the topic has been introduced, we will be talking about actually the latest in basal insulins, notably Glargine U300, insulin degludec, and with a passing reference of concentrated degludec 2, because that is not available yet in India. As Professor Sholil Pal has rightly pointed out, availability of basal insulin analog with glargine as the now which can be looked upon as the gold standard basal insulin, this has really changed the way type 2 diabetes and even type 1 diabetes is being treated. And the change has been most manifest in patients of type 2 diabetes, where we now have a very robust therapy, the basal insulin supported oral therapy, which can act as a bridge between, an OAD regimen and an otherwise intensive insulin regimen. So this has been possible because of the availability of insulin glargine, which we now are all aware of, has certain definite specific advantages over the good old NPH insulin. But then over the years, there have been refinements in the basal insulin analog segment also. Thus, we have the concentrated forms of glargine as well as another basal insulin, which is also quite popular, that is degludec. So the method of protraction of these insulins is a little bit different. In glargine, it is actually a pH-dependent method of protraction. A glargine is an acidic insulin which precipitates upon injection in the alkaline milieu of the tissue fluid. And from that depot, glargine is absorbed over a period of time slowly. Thus, its mechanism of protraction of its action. To further that, concentrated glargine, that is U300 glargine, when injected, forms a more compact subcutaneous spherical depot with a smaller surface area. That is, the sphere becomes more dense, and from this denser sphere, the insulin is released in a more protracted fashion. On the other hand, in insulin degludec, the mechanism of protraction is a little bit different, where actually a fatty acid is attached to the insulin molecule, and that binds with albumin and causes protraction of action. Now, these are a few trials which have compared various newer basal insulins. As you see, the addition trials mainly have compared glargine 100, which we can now look upon still as the gold standard basal insulin, because all the basal insulins are now validated against U100 glargine. So in addition 1, glargine U100 has been compared with glargine 300. And in the begin trials, glargine Idec, that is insulin degludec, has been compared against glargine U100, again that being the looked upon as the gold standard basal insulin. So in edition 1, it was a basal bolus study. In edition 2, that is basal plus OADs. In edition 3, in the insulin naive subjects, and in the Japanese version of edition, also with basal and OADs. So the edition trials looked at all the possibilities where we can use basal insulin, that is in insulin naive patients, insulin along with oral antidiabetic agents, and as a part of MSI. And to cut a long story short, what was the result? There was non-inferiority in efficacy between glargine U100 and U300. That is, glargine U300 is as efficacious as the gold standard glargine U100, but with lesser anytime hypoglycemia and nocturnal hypoglycemia. We know when we use insulin, one of the stumbling blocks of intensifying therapy and one of the stumbling blocks of insulin acceptance is hypoglycemia and weight gain. So if any refinement of insulin therapy that will take care of hypoglycemia will always be a welcome development. And second, my previous speaker, while alluding to U200 Lispro, have said, if you give a concentrated insulin, there are certain practical, technical benefits, like the volume of insulin injected being less, so there would be less pain or discomfort. The force that is needed to push a lesser volume of insulin through a pen injector would be also less, and which is maybe significant for patients in extremes of age, as well as patients with having rheumatological problems. So I think these advantages also would be there when you are using a concentrated insulin. When you compared the insulin degludec with insulin glargine U100, again, so far as glycemic efficacy is concerned, there is little to choose between the two. Insulin degludec is as good as insulin glargine in controlling glycated hemoglobin, but again, with a similar risk of anytime hypoglycemia, though there was less nocturnal hypoglycemia in Idec arm. So I think these are the forest plots of what I have said in a summary, that is the addition and begin trials, better safety with newer basal insulin. So with the basal insulin segment, the designer insulins, we have more or less nearly perfected the efficacy part, but the safety part, there was some unmet needs. Still there are, but there was some major unmet needs in the safety, that is notably hypoglycemia part, that has been to some extent taken care of with this newer edition basal insulins. Another terminology that we see here and look at these days is the glycemic variability and time in range or time in target. And you see between Glargine 300 and Idec 100, you see with Glargine 300, there was lower intraday glycemic variability. So again, we do not like the peaks and troughs. And with any insulin where the intraday or interday glycemic variability will be less, will be again a more welcome development. Another way of looking at it is the time in range or time below range. So again, if you compare insulin degludec with Glargine 300, that the time in range data really favored Glargine over degludec. Sorry, it's more or less same with Glargine and degludec, but time below range was markedly lower with Glargine 300 across categories of hypoglycemia. So we have certain head-to-head randomized controlled trials, Glargine 300 versus Idec 200 and Glargine 300 versus Idec 200. That is the conclude study. Well, we are quoting the BRIGHT study most often simply because Idec 200 is not yet available in India, but we would rather be interested in comparing a concentrated Glargine with a concentrated degludec because that makes a greater sense. So this was the BRIGHT study design. It was a multi-center, open-label, randomized, controlled trial trying to look at non-inferiority in adult participants with uncontrolled type 2 diabetes. I won't go into the details for the paucity of time, but suffices to say these patients were randomized to Glargine U300 vis-a-vis the Idec 100 in the two arms, and the patients were greater than 18 years, that is adult patients with type 2 diabetes and a glycated hemoglobin not less than 7.5 or not exceeding 10.5%. And what, so far as glycated hemoglobin was concerned, Glargine 300 and Idec 100 appeared same. There was not much to choose between, both in the titration phase and the maintenance phase. But when it came to hypoglycemia, that is overall daily hypoglycemia, the incidences of hypoglycemia were lower with Glargine U300 in the titration phase. Now, you may actually argue that in the maintenance phase, there is not much difference. So why make so great a noise about it? But the practical thing is that when you initiate and up titrate insulin in any patient, I think that is the most crucial phase, because if at this phase the patient lands up in a serious hypoglycemia, both the insulin and the prescribing physician earns a bad name in the psyche of the patient. Again, if you are too cautious and if in the fear of hypoglycemia, the up titration is slow enough, then you will take time to reach the glycemic targets that you fix for that particular patient, which may be a source of frustration to the patient. So if Glargine U300 causes less hypoglycemia, even in the initial titration phase, that can be looked upon as an important advantage when compared with degludec, because the cost of Glargine U300 and degludec is more or less similar in the Indian market. Next, we come to another trial. This is the conclude trial. As I have alluded to, this trial has compared the two new concentrated basal insulins, that is Idec 200 vis-a-vis glargine 300 when given once daily. Even there was a titration phase and a maintenance phase. They looked at basically the safety as well as efficacy, but the safety, meaning hypoglycemia, was the main part when they tried to look up at the safety of insulin degludec as compared to glargine U300. There are certain criticisms of the study, whether the glucose monitor was okay or not, but I'm not going into that. But what actually they found, there was not much difference in the overall symptomatic hypoglycemia and severe hypoglycemia, nocturnal hypoglycemia, and so on. And this study actually failed to meet the primary endpoint that insulin degludec 200 was superior to insulin glargine 300 so far as hypoglycemia is concerned. So, however, in the maintenance period, the final symptomatic hypoglycemia was better in the glargine U300 arm, though the insulin dosage was about 10% lower in the Idec 200 cohort. However, despite that lower insulin requirement, the body weight gain was to the tune of around 2 kilos. That may be due to, I do not know, maybe one we can surmise because of defensive snacking, because of more hypoglycemia episodes. To summarize, therefore, availability of newer basal insulins, really insulin injections have really revolutionized the treatment of type 2 diabetes and has made the life of type 1 diabetes much easier as compared to a time or to a scenario when we were using long-acting insulins like NPH, Lenti, and so on, because they were suspensions, had immense batch-to-batch, intraday, inter-day, and inter-patient variabilities that have been much lowered with the insulin analogs, that is notably glargine, U100, which again I reiterate is the gold standard basal insulin, having very long years of experience of its use. But further improvement in glargine therapy has been made with the availability of glargine U300, which has certain subtle safety benefits over glargine U100. And I am told Sanofi would be bringing glargine U300 cartridges this year, which will further decrease the cost of therapy, and there would be not much difference between the glargine U100 and U300. And therefore, in those patients who are requiring rather more dose, a daily dose of basal insulin, those who are having more fluctuations in the glycemic status with basal insulin, those where volume of injection, the pain of injection, and the driving force in the pain are an issues, they would definitely benefit using U300 glargine in preference to U100 glargine. So I think now we are celebrating 100 years of insulin. We are very proud and happy to say that now the clinicians and patients have a choice of many types of modern basal insulins to choose from to suit the particular patient, just as we would be also hoping in the COVID immunization scenario in 3 to 4 months time, we would be having umpteen number of choices to choose the best vaccine which one perceives from a basket of COVID vaccines. Thank you. With this, I end my talk, and if there are any questions, I would be glad to address them.
Nice.